Dear viewers, this video is part 4 of the 4-part series on lipid disorders in the Prescribon Medical Education series. Trans fatty acids. Artificial trans fats are created in an industrial process that adds hydrogen to liquid vegetable oils to make them more solid. The primary dietary source for trans fats in processed foods is so-called partially hydrogenated oils. They are used by food manufacturers because they have a long shelf life and are able to withstand repeated heating without breaking down. Donuts, biscuits, crackers, muffins, pies, and cakes are examples of foods that may contain trans fat. Trans fats may also be produced when ordinary vegetable oils are heated to fry foods at very high temperatures, and this is one reason why takeaway foods can sometimes be high in trans fats. While many old fashioned margarines contain a high proportion of trans fats, newer brands should contain lower amounts. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Atherosclerosis. Atherosclerosis is a disease of the large and intermediate sized arteries in which fatty lesions called atheromatous plaques develop on the inside surfaces of the arterial walls. Arteriosclerosis, in contrast, is a general term that refers to thickened and stiffened blood vessels of all sizes. One abnormality that can be measured very early in blood vessels that later become atherosclerotic is damage to the vascular endothelium. This damage, in turn, increases the expression of adhesion molecules on endothelial cells and decreases their ability to release nitric oxide and other substances that help prevent adhesion of macromolecules, platelets, and monocytes to the endothelium. After damage to the vascular endothelium occurs, circulating monocytes and lipids, mostly LDLs, begin to accumulate at the site of injury. The monocytes cross the endothelium, enter the intima of the vessel wall, and differentiate to become macrophages, which then ingest and oxidize the accumulated lipoproteins, giving the macrophages a foam-like appearance. These macrophage foam cells then aggregate on the blood vessel and form a visible fatty streak. With time, the fatty streaks grow larger and coalesce, and the surrounding fibrous and smooth muscle tissue proliferate to form larger and larger plaques. Also, the macrophages release substances that cause inflammation and further proliferation of smooth muscle and fibrous tissue on the inside surfaces of the arterial wall. The lipid deposits plus the cellular proliferation can become so large that the plaque bulges into the lumen of the artery and greatly reduces blood flow and sometimes completely occluding the vessel. Even without occlusion, the fibroblasts of the plaque eventually deposit extensive amounts of dense connective tissue. Sclerosis, that is fibrosis, becomes so great that the arteries become stiff. Still later, calcium salts often precipitate with the cholesterol and other lipids of the plaques, leading to bony hard calcifications that can make the arteries rigid tubes. Both of these later stages of the disease are called hardening of the arteries. Atherosclerotic arteries lose most of their distensibility, and because of the degenerative areas in their walls, they are easily ruptured. Also, Where the plaques protrude into the flowing blood, their rough surfaces can cause blood clots to develop with resultant thrombus or embolus formation, leading to a sudden blockage of all blood flow in the artery. Almost half of all deaths in the United States and Europe are due to vascular disease. About two-thirds of these deaths are caused by thrombosis of one or more coronary arteries, which supply the heart. The remaining one-third are caused by thrombosis or hemorrhage of vessels in other organs of the body, especially the brain, causing strokes, but also the kidneys, liver, gastrointestinal tract, and limbs. Roles of cholesterol and lipoproteins in atherosclerosis. Increased low density lipoproteins, LDLs. An important factor in causing atherosclerosis is a high blood plasma concentration of cholesterol in the form of LDLs. The plasma concentration of these high cholesterol LDLs is increased by several factors, especially by eating highly saturated fat in the daily diet, obesity, and physical inactivity. To a much lesser extent, eating excess cholesterol may also raise plasma levels of LDLs. Familial hypercholesterolemia. In 80 to 90% of patients with familial hypercholesterolemia, the person inherits defective genes for the formation of LDL receptors on the membrane surfaces of the body cells. As a result, the number of VLDLs released by the liver into the plasma increases immensely. Patients with full-blown familial hypercholesterolemia may have blood cholesterol concentrations of 600 to 1000 mg per deciliter, levels that are 4 to 6 times normal. If untreated, many of these people die before the age of 30 because of myocardial infarction or other sequelae of atherosclerotic blockage of blood vessels throughout the body. Heterozygous, heterozygous familial hypercholesterolemia is relatively common and occurs in about 1 in 500 people. Note, heterozygous means having two different alleles of a particular gene. The portion of a chromosome derived from each parent is usually similar, but in heterozygous state they are different. In this case, the defective gene is only from one parent. The other allele is normal. The more severe form of this disorder, caused by homozygous mutations, is much rarer, occurring in only about 1 of every million births on average. Note, homozygous mutations means the defective gene's representation from each parent is the same, resulting in increased severity of the disease. Role of high density lipoproteins in preventing atherosclerosis. Much less is known about the function of HDLs compared with that of LDLs. It is believed that HDLs can actually absorb cholesterol crystals that are beginning to be deposited in arterial walls. Epidemiological studies, that is, population studies, indicate that when a person has a high ratio of high density to low density lipoproteins, the likelihood of developing atherosclerosis is greatly reduced. Other major risk factors for atherosclerosis. In some people with perfectly normal levels of cholesterol and lipoproteins, atherosclerosis still develops. Some of the factors that are known to predispose to atherosclerosis are 1. Physical inactivity and obesity, 2. Diabetes mellitus, 3. Hypertension, 4. Hyperlipidemia, 5. Cigarette smoking. Hypertension, for example, increases the risk for atherosclerotic coronary artery disease by at least twofold. Likewise, persons with diabetes mellitus have, on average, more than a twofold increased risk of developing coronary artery disease. When hypertension and diabetes mellitus occur together, the risk for coronary artery disease is increased by more than eightfold. When hypertension, diabetes mellitus, and hyperlipidemia are all present, the risk for atherosclerotic coronary artery disease is increased almost 20-fold, suggesting that these factors interact in a synergistic manner to increase the risk of developing atherosclerosis. In many overweight and obese patients, these three factors, these three risk factors do occur together, greatly increasing their risk for atherosclerosis, which in turn may lead to heart attack, stroke, and kidney disease. In early and middle adulthood, men are more likely to develop atherosclerosis than are women of comparable age, suggesting that male sex hormones might be atherogenic, or conversely, that female sex hormones might be protective. Some of these factors cause atherosclerosis by increasing the concentration of LDLs in the plasma. Others, such as hypertension, lead to atherosclerosis by causing damage to the vascular endothelium and other changes in the vascular tissues that predispose to cholesterol deposition. Prevention of atherosclerosis. The most important measures to protect against the development of atherosclerosis and its progression to serious vascular diseases are 1. Maintaining a healthy weight, being physically active, and eating a diet that contains mainly unsaturated fat with a low cholesterol content. 2. Preventing hypertension by maintaining a healthy diet and being physically active, or effectively controlling blood pressure with antihypertensive drugs if hypertension does develop. 3. Effectively controlling blood glucose with insulin treatment or other drugs if diabetes develops. And 4. Avoiding cigarette smoking. Several types of drugs that lower plasma lipids and cholesterol have proved to be valuable in preventing atherosclerosis. Most of the cholesterol formed in the liver is converted into bile acids and secreted in this form into the duodenum. Then, more than 90% of these same bile acids is reabsorbed in the terminal ileum and used over and over again in the bile. Therefore, any agent that combines with the bile acids in the gastrointestinal tract and prevents their reabsorption into the circulation can decrease the total bile acid pool in the circulating blood. As a result, far more of the liver cholesterol is converted into new bile acids. Thus, simply eating oat bran, which binds bile acids and is a constituent of many breakfast cereals, increases the proportion of liver cholesterol that forms new bile acids rather than forming new LDLs and atherogenic plaques. Another group of drugs called statins competitively inhibits hydroxymethyl glutaryl coenzyme A, that is HMG-CoA reductase, a rate-limiting enzyme in the synthesis of cholesterol. This inhibition decreases cholesterol synthesis and increases LDL receptors in the liver, usually causing a 25 to 50% reduction in plasma levels of LDLs. The statins may also have other beneficial effects that help prevent atherosclerosis, such as attenuating vascular inflammation. These drugs are now widely used to treat patients who have increased plasma cholesterol levels. In general, studies show that for each 1 milligram per deciliter decrease in LDL cholesterol in the plasma, there is about 2% in decrease in mortality from atherosclerotic heart disease. Therefore, appropriate preventive measures are valuable in decreasing heart attacks. Dear viewers, this is the end of the video series on lipid disorders in the Prescribon medical education series. Thank you for viewing the videos.